Hey guys, welcome back to another episode of the Mind Muscle Connection podcast. Today I have a very special guest on for the first time, Mike Laviolette. He is a physiotherapist and a online fitness and health coach. So Mike, actually we met through online trainer mentorship legacy. He's in the same program as me and we were able to connect and everything. And yeah, I think with you being a physio, I haven't had any physios on in the past. So I think this will be a good episode here. If again, just something I haven't really dove into before with any guests. So I think it'll be a lot of insight in here for people. But yeah, Mike, really appreciate you coming on, man, and looking forward to chatting with you today. So what I typically do with any new guest is just a little brief background on yourself and how you got into fitness, how you got to where you're at today. So I'll hand it over to you. And again, thanks for coming on today.
Yeah. Thank you for having me, Jeff. My background really initially was in music, and I taught music for 11 years. So I still consider myself a teacher, and everything that I do, I guess you could say that's my main gig, is teaching people, but decided to get into health and fitness. I had a transformation myself. I went through some tough times. I was morbidly obese and started training, fell in love with bodybuilding and body composition, and decided that I actually was going to be a registered dietitian. I was like, oh, this is what I want to do, nutrition, and have a passion for. But just what they described it to be was not quite what I wanted to do. And I knew that I loved movement. And so I said, you know what, physical therapy, that's the thing that I want to do. So taking some classes in nutrition through my bachelor's degree. So where I went to school, their degree was health sciences. So that's what my bachelor's is in. Yeah, I studied a lot of strength and conditioning literature, even through that. But I got my DPT, Doctor of Physical Therapy. Then I went on to get specialized in orthopedics. I did a residency in orthopedics, and then I specialized in orthopedics. So that really is my background. I would say more specifically, my background is being able to take a look at the literature and analyze it really well. So I think that's one of the big things I got out of DPT school.
Hey, you fit right in coming on to this podcast. We love going over science and stuff like that. And again, you have a little, again, I feel like all this stuff is relatively similar, exercise, nutrition, right? But you have a very yours, I would say, falls off another branch there of physical therapy, probably slightly different. But again, love that you look at the research and stuff. I think that's super important there with that. I didn't know you were in music before. I know you did have a transformation. I've seen it on social media. So you started in music, and I'm assuming did you have that transformation before you decided to go into physical therapy, or was it afterwards?
It was before physical therapy. It was interesting, man, because I was seeing Muscle and Fitness magazine. I'm dating myself maybe, but it was still in the aisles at the grocery store. So I was seeing that stuff, and I was like, man, that's how I wanted to look. And got into the gym, started training, and I was seeing all of these really big guys. And I think being enhanced was something that everybody was trying to hide then. And I was like, hey, if I come in and train, I can look like that. And so I did that. I didn't quite look like that. I trained for a while, and then I started cutting and got pretty lean, probably maybe not stage lean, but leaner than beach lean. And I was pretty small potatoes. I said, why is it not working? But yeah, it was after my being a piano instructor for a long time, which was my first degree. Yeah.
What was your kind of transformation like? What was that weight loss wise? What was the kind of your transformation story there?
Yeah. So it was an interesting one. Honestly, I knew that I needed to be in a calorie deficit, but I didn't know much about. As I started looking at research, I knew that macros were something I need to take a look at, but I needed to be in a calorie deficit, and the protein was important. So it actually turned into some disordered eating. I wouldn't call it an eating disorder, but I would say disordered eating, where I would be good, right? Like air quotes, good on the weekdays. And then I would binge on the weekends. And that's how I went into my first transformation, my first physical transformation, because what I really needed was a mindset transformation to be able to do that in a healthy way and in a way that was going to benefit in optimal hypertrophy and maintenance of muscle protein as I was going through a cutting phase. So that was really my first transformation was a physical transformation, but I didn't quite have that mindset yet. And I didn't have the knowledge to be able to do that.
Yeah. I commonly see it's usually people get into it. They want to change that physical side of thing. And then I just have always found that, man, that mental side of things really ends up being a sticking point and a big bottleneck for a lot of people. If you can get through that, like you said there, if you need to be in a calorie deficit, you'd be quote unquote good, and then you'd fall off. And that I think that's where that mindset really comes in. And I find that that's something that people really have trouble with. And it's often overlooked. They kind of brush that to the side and they think it's just, hey, macros, training, and that stuff's super important. Your mindset, man, that really goes a long way, especially if you want this to be something that becomes lifelong and you really want to make that change long term as well, too.
Yeah, absolutely. Yeah, I couldn't agree more. The mindset was if you don't go into it with the right mindset, it can get unhealthy, some anorexic type behaviors, right?
Yeah, you hit on that a couple times. Is that kind of where your mindset side of things? What was the mental like kind of transformation? Was it like, yeah, I guess what were some of those things for you?
Honestly, it was just diving deeper into research. I didn't really know about science. I'd always respected it, but it wasn't something that I was deep into. And I think dating myself again, I got into the bodybuilding.com forums.
Yep.
And Lane Norton was all over those. He was like running the forums, I think. And Kane, I think his name is Kane Sumabat. He's like Timberwolf on Instagram. He was in there, but it was enlightening for me to hear some of the stuff and then dive into it really and check it out. So then I started writing these programs for myself. And as I got deeper into it, started writing them for friends, got into a lot of the nutrition side of things. And when I think a really big transformation as far as training was when there was like a power building phase that was popular on YouTube. And just understanding the relationship between strength and hypertrophy and how this stuff was really so important. The training side was so important. And I was committed from day one to the training. I really fell in love with it. But I think that was all part of the transformation. And I think really just to circle back, understanding the literature and diving deep into that.
Yep. Yeah, no, it's a nice tool to have, and it's a good tool to learn how, especially too, I feel like in today's world, man, where with social media, it's just, you see all these studies get thrown around. So if you can really learn how to dissect them and look into them more, I always tell people that come on here, I'm like, man, for the longest time, I always heard, hey, don't just read the abstract. And it never really clicked. I'm like, well, it tells you everything you need to know here. And then as you learn more, you look into it more, you talk to people who do research, you're like, okay, now I, really understand why they said, don't just read the abstract, because there are so many variables that could potentially be off, especially when it comes to like nutrition and exercise and stuff. It's a good skill to have. And yeah.
Yeah. You can't be an abstract scientist, pun intended, I guess there, but yeah, I think getting into the methods and materials and the results and skewed data and financial bias. And there are just so many variables within a study. And then when we're talking about research involving humans, there's this psychological aspect of the human. And then the psychosocial, really, obviously the psycho is involved with the biosocial element that's there. And not every human is the same. So I think we have to take the data at face value and apply it to the individual. So yeah, it's important not just to read the whole thing, really dissect it.
Yep. So I'm curious to hear a little bit more about, so you became a doctor of physical therapy. How long did you do that? And how did you transition to where you're at today?
Yeah, I graduated. So I really started working in the field in 2014, graduated 2017, and just really was into the research. And when you go on to do a residency, it's like a fellowship as an MD. Your residency as a physical therapist is as you're going through school. So you're working in the field. And I decided I wanted to get postgraduate education. So I did a residency because I was so deep into the physical therapy research. And this was a good, like an outlet for me to go a little bit further with my education there. And it gave me a few different pathways that I could go down and opportunities. So I did that. And then I did the orthopedic specialist exam. I got those letters after my name, and I just continued to gather letters. And so I worked until 2020. And when the shutdown happened, I realized that I didn't want anyone telling me what to do. That's one thing that I really had all my life is I don't do well when people are telling me what to do. I need guidance. I don't need people telling me what to do, but it probably goes a little bit deeper than that. And so I'll get into this a little bit about how, as a healthcare professional, it's really easy to get burnt out. And there's 4 kind of characters in this broken system. And we'll start with the insurance companies, right? The insurance companies keep reducing compensation and reimbursement for the clinics and treatment, right? So the clinic owners need to continue to make money. So they need to bring in more people, more patients or clients. They'll get those to be able to make money, right? And so as more people are coming in, more patients are coming in, so that the clinic can continue to run and make money. Physical therapists and any healthcare professional is seeing more people in a physical therapy clinic, right? Like you want to give high quality care. You want to make sure that you're giving the best care that you can, because that's what you're getting taught going through school. It's what you're getting taught in postgrad and in research. We see that when you have a strong therapeutic alliance, outcomes are better. And so that's where physical therapists can get burnt out. They're not doing the job that they thought they were going to be doing. And they're just seeing so many people and going through so many notes that they get burnt out. And people that are coming in, patients, are getting poor care. They're not getting the care that they deserve. And so I needed to break out of that system. So I guess it's twofold, right? The first thing is I didn't like people telling me what to do. But an even bigger issue that affects so many people is this broken healthcare system that we have here in the United States. So that's how I got to be where I am today. I stumbled upon coaching, different one than we met in, but I stumbled upon some coaching that was for healthcare professionals and online business coaching, and developed. Things took off from there. And I said, you know what? I'm never going to work in the clinic again because I don't have to. People are doing much better than I'm able to work with people in a way that I wasn't able to work with them when I was in the clinic. And because of that, outcomes are better. People are getting stronger. They're working past what they could from an injury in the clinic. And people are working towards their goals, whether it's peaking for a strongman competition or getting really lean. And those are just some of the things that I couldn't work with people on in the clinic that I have a deep knowledge of. So,
Yeah.
so I feel like I could never go back there.
Yeah, no, absolutely. Yeah. It sounds like it was, again, like you said there, it's like, in order for the clinic to make money, they got to bring in more people because, like you said, the insurance companies they're lowering the costs. And so, you got to get more people in, but when you get more people in, it's like now that level of service drops down and you just feel like you're churning through people and you don't give them that level of care that you feel like they deserve. So it sounds like that was one of the main reasons with it. And it sounds like that's how it is with not only, physical therapists, but doctors as well too. I mean, it seems like it's the same issue there with that from my understanding.
It absolutely is. When's the last time you went to the doctor and they see you for 5-10 minutes and they got to skip to the next one? They're always like, I think of my last physical, they were 40 minutes late. And it's tough when you're 40 minutes late and you got a call with a client, then you got to push back, but there's got to give them some grace there, because I've been in that position and it's like, hey man, I understand. It's not your fault. It's the system that we're working in.
So you did that for, it sounded like what, three-ish years or so. So was it like you and a couple other doctor of physical therapy that worked within this clinic? Was it your clinic? What did that kind of look like?
Yeah. So I live in Massachusetts, where I'm from. And to do the post-grad work, I moved to California, was working at a Kaiser Permanente there. And it was a great experience with a lot of great mentors. Patients would have to wait 2 weeks to get their next appointment. I was working in a 10 by 10 room. There really wasn't access to the gym because they had an ACL rehab class and knee replacement rehab classes that would take up the gym. So it was like, I'm just doing these like small exercises that are good, but the movement needs to be a little bit more than that if we want to maintain positive outcomes. So that's where I started. And then when I came home, I was working in a clinic that they weren't as up to date on research, and they were practicing in an old model. So I didn't really fit in well there. And I was like, you know what, I'm going to start to contract. So I started to do some contract work, and I was in a contract where there were probably 2 other clinicians. They were permanent employees there. So they got furloughed. They had to fulfill a 30-day notice on my contract. So I worked another 30 days during the pandemic and then left. That's from the time I graduated to when I stopped working in a physical therapy clinic.
What can you maybe dive into your specialty a little bit more? I know you said you did some extra schooling. I think you said something orthopedic. I don't know the exact specialty there, but what does that kind of look like? And yeah, fill me in on that a little bit more.
I guess you could say muscles, joints, bones, ligaments, tendons. So really that kind of stuff, because there's different specialties in physical therapy. There's like a neurological specialty. There's a pediatric specialty, and they still do deal with movement, but I would say it's less pain oriented. Probably what I do is a little more oriented around pain and recovering from surgery and getting back to lifting, I guess, for the people that I'm working with right now. But whatever physical activity they want to do, that's really more in the realm of orthopedics and sports physical therapy, because there's sports physical therapy as well, but most of them work on, I would say, on sports teams. And it's really oriented towards sports, really, I guess, like the bigger sports where the movements are a little more athletic, and it's like power movements, not power as in powerlifting, right? Because we in physics, right, it's not quite power, that's strength, but power movements. So that's what sports specialty is really about. But so yeah, a lot of what I deal with is pain and getting people back to what they want to be doing.
And I'm assuming probably some of it is, so obviously pain, getting them away from pain, or like they come to you, they have pain or they have some sort of injury, but also I'm assuming probably preventative as well too, especially now the role that you're in now, it's probably maybe even a little bit more preventative than it was in the past.
Sure. Yeah. Pain is an interesting thing. We could get into the role of the brain on pain, and some people may never leave pain. They might always be in pain. But I think at that point, it's like, all right, can we get you to do more than you're doing now? I guess we refer to that as central sensitization. But yeah, so that's really trying to get people to do more, trying to get people out of pain, I guess you could say. Yes, guiding them and giving them independence as far as what they can do to be active and possibly avoid pain. And you mentioned avoiding pain in prehab, I think you say, to stay away from injury. And I'm not sure that we can actually do that. We can decrease the likelihood, we can decrease the risk, but there's always a risk, right? So yeah, that's really what, as far as the role of a physical therapist that I'm in, yes, that's what it would be.
We talked about how you were in a clinic, now you're a health fitness coach at this point. Do you still maintain the doctor of physical therapy? Is that something that you have to keep up on from like a continuing education standpoint? I'm assuming everything you learned, you're still applying, obviously, with your clients that you work with virtually and everything like that. But yeah, I'm curious to hear a little bit more about that in terms of maintaining it. I'm assuming you still practice a lot of what you learned over the years with your clients and things like that.
I do. Yeah, we have that we have to keep up on. I think there are specific things that I have a greater interest in, that there's so many different areas that you can stay up to date on. And for that education, I do try to keep up on concussion, whiplash associated disorder, that kind of stuff. When I was working in the clinic, a lot of, I would say, like, my specialty within the specialty was head and neck. So cervicogenic headaches, neck pain, which is really tied to thoracic. And if you've lifted, that's a place that you can get really tight, like the thoracic spine. So that's probably a lot of the continuing ed that I do. But most of the research that I look at is probably has to do with hypertrophy and nutrition. So that's what I'm in. But yes, to keep up, I do keep up a knowledge of physical therapy research, things around pain, things around tendinopathy, which I guess you could say tendonitis, right? We call it tendinopathy now. There's kind of two camps on what it really is, what's really going on, and what happens there. But the things that apply to lifting and that apply to the people that I'm working with are things that I try to stay up to date with. Yeah. And there's a lot of research actually there's a lot of courses, you could say, on powerlifting. And that's become something pretty big in physical therapy. So yeah, I try to stay really up to date with that.
Yeah. Those are the people you work with now, when you're able to, I'm assuming you're probably able to be a lot more specific now than you would have if you were in a clinic, right? Because you're limited to who comes to you and stuff. Whereas now you can be a little bit more specific to, like, hey, if you're working with people on body comp stuff, hypertrophy training, and I want to dive into this with you, but you can look into the research on things that are a little bit more specific to that versus, again, probably some of the other injuries that you would get and things that you would get from people in the clinic and stuff like that as well.
Very much so. I still have people that search me out from the clinic, and I'm actually working with someone right now who has a TMJ issue, temporal mandibular dysfunction. And there's actually a disc in that joint, like in the back, and it gets displaced every time you open your mouth, but then it gets reduced, right? So it goes back in, and this gentleman, it got displaced and it's not going back in, so he can't open his jaw. So he sought me out. That's not much of who I see now, but I still do have those people that seek me out. But yeah, I can get a little more specific on that. And a lot of it is on training load, managing fatigue, stuff like that. So yeah, absolutely. Cool. And reducing risk of injury. Absolutely.
Cool. Yeah, no, I want to dive into that stuff with you because I think that will be really specific for people that listen to this podcast. But I guess real quick, before we get into that, you hit on the role of the physio. And again, I'm assuming physio and physical therapist are basically interchangeable, because I've always wondered that. I've heard physio, but I'm assuming they're basically interchangeable there with that. So I guess maybe if you want to hit on what is the main role of the physio and physical therapist. Again, I'm assuming it's probably context dependent, but it's the main role. And then I want to dive into maybe some things people get wrong with physical therapy and physios and things like that.
It does. It's really context dependent. I'll just dive into me, in my experiences, if someone is a coach and they have someone going through an injury, say they're doing overhead press, right? Some dumbbell overhead presses, and they happen to have a tweak and they've got a shoulder issue, and that coach sends them to me. It's my job to work with the coach, right, in tandem. We're going to modify the program. We're going to maybe do some stuff that's a little more specific for the shoulder. We're going to manage load there. And we're going to try to streamline things so that we can get them back to that coach as quickly as possible, right? So I think that's my role there when I'm working with another coach. So that's really important. That's my job, is to get them back to another coach as soon as possible, as healthy as possible, and at a time where it's appropriate for them to go. And with communication that whole time, because I look at it as a team approach, right? And when you're in the clinic, you're working in healthcare, you're talking to the sports med doc, or you're talking to the orthopedist, right? It should be a team approach. So that's how I like to look at it as far as when I'm working with another coach. And I have someone specific right now. I'm thinking she has a powerlifting coach and she's hitting PRs, definitely stronger than me. She's great. But she was looking for some nutrition help. So I actually work with her on nutrition and really getting her into her weight class and maybe cutting down slowly a little more slowly than she usually does, and getting her to eat into the show so that she's really well energized into the show. Now, I know this is probably, it's not beyond the scope of the physio, right? Because the only thing that would be is treating disease with nutrition, right? So you can consider wellness, but maybe an abnormal role. But that's what we're doing there. And just, I guess it's a team approach there. As far as when I'm working with someone as a physio, when they seek me out, that's the first thing that we're doing, is we're taking a look at what they want to do. Where are you coming from? How do we get here? And where are we going? Right? Past, present, future. And so we take a look at what they've done in the past. We take a look at where they are, what they can do, and we do as much of what they can do as possible, right? Because this is what's going to get them motivated. And this is what's really going to get them on the path back to, they say, squatting. So I think we chatted a little bit about this. I don't know if it was already on the show, but I had someone come to me. He was having back pain. He was having knee pain. He was squatting relatively heavy, definitely stronger than me. He was squatting in the 400s. And he had a tough time with 135. And so that's where I met him, to meet them where they're at. We did squat. We modified depth. We modified frequency, we modified volume, we modified intensity. So really with him, we had to modify all those things, but we got him deeper into the squat. And I'm thinking specifically for the knee issue, we got him deeper in the squat. We've been working together for maybe a year and a half, and he just did a strongman show. And he's squatting pretty heavy. He's in the upper 400s at this point, hitting PRs. I would say going from physio to coach, that's really where we're at. And I still am in that role of physio, but I'm in the role of coach. And that role of physio and coach is very similar, because when you think about movement, it's a spectrum. Movement is rehab and rehab is movement. We're still training, right, at the lower levels, but we want to get someone on the other side of that spectrum. So long answer, but I think in context, that's my role as a physio.
Yeah, no, super helpful. So like, when would, somebody like me refer out to a physio, and like under what situations? Again, is it just like, hey, someone is having, like, when they're doing some sort of movement, they're having pain, or what does that look like? Who would I typically refer out to the physio and physical therapist?
A lot of it depends. It's an N=1 situation, because it depends
Absolutely.
on your knowledge, right? It depends on your knowledge and what you're comfortable with. But you also don't want to take someone so far that now we have an injury that's like a labrum tear, and they're considering getting surgery. They're like put off by you. They're like, this coach injured me, and now I'm going to see the ortho physician, and they're telling me I might need surgery. So I think, I don't want to say it's your call, but you have to know where the cutoff is. And if someone is having pain for longer than 2 weeks and you've modified the program, then it might be time to refer out and have it at least looked at. There are definitely some red flag situations. If someone can't abduct their arm past 30 or 90 degrees, definitely time to refer out. If someone is having pain, if they had a back tweak, they're having pain down both of their legs, or they're having tingling down both of their legs, or even one of their legs, right? So if they had a back tweak and they're having pain below the gluteal fold or down into their foot, or they're having tingling down into below the gluteal fold into their foot, that would be time to refer to a physical therapist. So I think it's really context dependent. And I absolutely encourage coaches, personal trainers, anybody who's taking someone through a movement program to study some of that stuff. I think it's important to study some of that stuff, and maybe you won't step into that role as a physio, but just important to know. But there are some definite red flags where you should refer out, and there are some other red flags where you should send them to an ER. Like if they don't have bowel or bladder control, you're not sending them to me, right? Like I'm not the guy. Send them to the ER. That's a big problem.
Yeah. So again, if it's like some crazy extreme situation, it's, hey, you're not sending them to physio like that, like you said, ER in that situation. But if something's, again, they're not able to do something, it's a couple weeks, it's not getting better, hey, maybe we refer out here. Like you said, you also made changes to the programming. And again, we'll talk about what some of those changes can be. Then at that point, hey, getting into referring them out is going to be helpful there. What would you say are like some common misconceptions and mistakes people maybe have towards physios and physical therapists? Yeah, there with that. Again, what they can't do, or yeah, is there any like common misconceptions that you hear out there?
As far as scope of practice or what they are, or
scope of practice, what they are, and then just like maybe just any misconceptions that people just generally have about physical therapists. So again, a lot of different ways you could take that, but
yeah, I think is scope of practice. There's the health and wellness, and I don't like to say that I'm in health and wellness, but I guess that's the bucket for when you're thinking of physical therapy. That's a bucket that you could put me in, right? Getting people stronger, helping them with nutrition. In the United States, if you're treating, you can't give meal plans. So I can't tell someone like, all right, this is exactly what your breakfast is going to be. This is exactly what your lunch is going to be. That's something I definitely don't go into. And I like to leave options open, right? Hey, these are the calories. And if we're even deep enough to talk about macros, these are the macros. And this is what you have on a day-to-day basis. And maybe this is what you partition for a meal. But I think that's even too specific. And I like to give people a little more freedom than that. But that's one thing, you can't do. And another thing you can't do is treat a disease. So you wouldn't be giving someone a meal plan or nutrition to bring them into diabetes remission. And I guess but you could. The things that you're going to do with them could bring them into diabetes remission. But there are other diseases that you cannot treat, right? Like you can't go in and put something in someone's IV, which I would never be way beyond my scope. Not interested in doing that. As far as what I do in scope of practice, those are my limitations. And then as far as what people think about physical therapy that are misconceptions, and some people might be right on this, right? Some people might be right, but it depends on the physio that you're going to. If you're working with a physio that's up to date and understands the literature and that the body is adaptable, then these misconceptions are wrong. But people think it's about posture, right? And I like to say that your next posture is your best posture. Like sitting for long periods isn't good. But if you were to stay in what people might consider perfect posture for a long time, that also isn't good, right? Like you think of I don't know if you've ever been in a cast, but anybody that's ever been in a cast or a cam boot, your joint is in a specific position. And when you get out, it's pretty hard to move. So you really want to keep things moving as much as possible. And there's no inherently bad posture. Your body is supposed to move into lumbar flexion, right? Like you're supposed to move at the back. And that's what people see physical therapists does, is they're gonna fix your posture. That's another thing, that we can't actually fix your posture. We can't realign people. If your morphology is a specific way, say your shoulders are forward a little bit, like maybe we can get some musculature hypertrophy back there and it's going to give a little more tug, but that's just how you are morphologically, then that's not something we can fix, right? We just can't do it. Like no one can do it. So I think that's a big misconception that people have. And I think another one is that you send people to them for these small exercises and that they only give small exercises. And maybe when someone is practicing and then they're not up to date on the literature, they probably only give those small exercises. But if you want strong, robust people who are hopefully out of pain, you have to give them strong, robust movements that challenge their muscles and their joints and their tendons, because that's just how we adapt as humans. And I think that's a misconception. As I said, to circle back, hey, maybe that's not a misconception when you're thinking of certain physical therapists, because I know from working in the field, that's what some physical therapists do. And it's unfortunate because I think it gives our profession a bad rap.
I'm glad you went that route because you answered it all. Went over like your kind of scope of practice, but you also hit on what people get wrong. Like for the posture, for example, that's one I hear all the time. Oh, I have poor posture. I need to fit. It's like you said, there's no bad. It's just you need to make sure you're going through different movements and you don't want to spend too much time in one specific posture, whatever you want to call that. So I think that's great. But you also hit on the hey, here's a misconception that people think towards physical therapy, but there's still people that, like you said, don't stay up to date on the research, and those physical therapists are doing those things. So I'm glad you went that route. And you mentioned where you said that there's a lot of people in the field that do that, and it gives physical therapists a bad rap. The reason I wanted you to hit on that is because it's the same thing with coaches, right? There's good coaches and there's bad coaches, right? And unfortunately, the bad ones tend to like give the industry a bad rap. I can totally relate to that and understand that, hey, no matter what, there's always in any field, there's going to be some good ones, there's going to be some okay ones, and then there's going to be some bad ones, but people are really going to focus on the bad ones, unfortunately, and they give the industry a bad rap. So I'm glad you went through all those. I think that was super helpful and yeah, really in depth. I don't know if you have any follow-ups on that or anything.
No, I just think I think it's an N=1 situation. I just want to reiterate and reinforce that you have to take a look at who you're working with. And I think for the people who listen to this podcast, do your research, right? No, just because someone has a bunch of letters after the name, just because I have letters after my name doesn't mean that you should trust me, right? You're going to want to do some research, maybe talk to somebody that I've worked with, or look at what I've done. Letters it's not everything. So you got to find a good one and seek them out, because you could just go to one because they're the closest one to me, or this is the person I'm seeing pop up on my feed all the time. So don't just go to that one.
Yep, absolutely. Do your research on it and look into it, and don't just look for the person closest to you and everything like that. So cool, Mike. So I want to switch gears here just a little bit, but I want to talk about risk of injury when it comes to weight training, and what is that compared to maybe other forms of exercise, and then we'll dive into how can we maybe prevent it. What are some things we can do there? And so we'll start there with that.
Sure. When we think of injury risk, every injury is the same in that it's too much too soon. You think of a tendinopathy, which is like there can be acute tendinopathies, right? Or acute tendinitis, which you might call it. The similar thing depending on which camp you're talking to. But if you think of a tendinopathy, it's too much too soon, like been doing too much and it's not recovering, right? So we know there's micro tears, micro damage that happens in muscles. That's how we get stronger. That's how we hypertrophy, but you're not giving it a chance to heal, right? So that was too much too soon, just over a long period of time. You think of a fracture, bone fracture, as like way too much, way too soon, right? Maybe I think I had a fracture, right? I had a compound fracture of my tibia and fibula, and it just was like a hit. Someone's knee went into the side of my leg and the bone broke. So it was a case of too much too soon. You think of a Muay Thai fighter who's been grinding that bone and kicking and using that shin to kick a lot. It's probably more adapted and might have even withheld something like that. Just starting off with injury, they're all the same. It's too much too soon. But the risk of injury, it depends on what we're doing. And you're thinking about bodybuilding style training. I think it's there's like a 0.2% chance of injury per 1,000 hours trained. I think the next highest is powerlifting, and it goes up to like strongman. Even CrossFit's below strongman. I think it's 0.8. And that's up there with basketball. I think everybody plays basketball, right? You play basketball when you're a little kid, which you're probably a little bit more durable when you're a little kid. You can come back from things a little bit easier, but because you're still in development. But it's 0.8 per 1,000 hours played is the chance of risk that you have playing basketball. So doing something, I think general population looks at weightlifting as something that's dangerous, when really it's the safest athletic event that you could do, or athletic activity that you could do. I think that's another misconception that probably the general population has. And some people may not even know that lift. They might think it's a risk what I'm doing, when really if you compare it to basketball, which you probably played all growing up, the risk is really low.
That was my understanding of the literature. Is again, like it depends on what type of, because weight training, like you said, it can be many different things, powerlifting, strongman. Within that, in general, weightlifting is pretty low, but then obviously you go within it, it's like certain ones are a little bit higher. But like you said, bodybuilding, hypertrophy style training, that tends to have the lowest kind of injury risk. And this is why I always try to make this point to people about why I think you should transition over to this if your goal is to just be healthier, look better. I think that this is the way to go for this reason. It has the lowest injury risk. And I'm sure you can agree with this. With hypertrophy, how can we structure training to where you can get the most productive training in for the longest periods of time, right? And that's ultimately what we're looking to do here. So if you're injured, you're not going to be able to train. That's going to hurt your hypertrophy, at least in certain muscle groups, right? That's why I'm a huge fan. It looks like you have something to say. I didn't know if there was something I said that you want to comment on there.
No, I fully agree with everything you said. No, that's great.
Cool. So again, I wanted to hit on that first of what is the risk of injury with like weightlifting? And again, you went through each one. Each one is going to be a little bit different, but again, hypertrophy style training, again, what we would call bodybuilding style tends to have the lowest. And again, like you said there, it's my understanding is it's more of an acute type injury, right? I think with like hypertrophy style training, and again, correct me if I'm wrong here, I would say probably the biggest issue is potentially like more of this kind of like overuse type injury, probably with it, right? Or what are the most common injuries that you see? This is something that I wanted to ask you.
Yeah, I definitely tendonitis or tendinopathy is a really common one, a low back tweak. And we call it non-specific low back pain because when it comes down to it, there are so many structures in there and it's so layered that we can't really, even with an MRI, we can't see it. Because when you look at, I'm 42 years old, I definitely have some arthritis and there are some discs that are probably bulging. I have no symptoms. It's just a normal thing, right? So we can't really, when we get it imaged, MRIs, we can't really say what the factor is. So low back pain is definitely a big one. I think those are the two biggest. I think those are the two biggest, really. Yeah, low back pain is a big one. And probably knee pain. I would say probably knee pain, patellar tendinopathy, patellofemoral issues. Those are probably the three biggest, I would say.
So you said tendinopathy there with that. And is it any particular muscle? Is it elbow that you typically see like that area? Or is there any particular, you said knee as well too. What would you say are like the most common ones that you would see from a hypertrophy, somebody just wants to improve their body comp type of exercise and stuff like that?
Yeah, for tendinopathies, I think a really common one is elbow extensor tendinopathy or lateral epicondylitis or tennis elbow, medial epicondylitis, which is golfer's elbow. So those two things are pretty common tendinopathies I see. Patellar tendinopathy is also a really common one when people are squatting or really doing extent like quad extension. So those are probably two common causes. I can't call them causes. I can just say that they're activities that maybe are overspecified because I think when, at least with the population I'm dealing with, right, that's what they know. They know to get on a quad extension machine. They know to squat. Those are two things that are really common. And I think probably those are why I see, and this is just for me, I can't state this by the research, but I think those are probably the most common ones because when people come to me, like that's just what they know if they have experience in this training. And yeah, I can say that, yeah, that's the tennis and golf elbow for sure are pretty common.
Yeah, I do want to dive into like how to avoid, but since we're on the topic of tendinopathy here, one that I commonly see is elbow area. So that's why I was asking about that. Again, is it just, I guess maybe talk about, again, I know there's probably not just one cause, but what are some things that generally lead to some elbow tendinopathy?
So I would say over specificity where there's not enough variation in your program. That is a very common cause. Or go ahead.
Well, real quick on that, when you say that, is it like too much like of doing like the same type of exercise? So if you're doing like bicep curls or something, so you're doing the same type of bicep curl, you're not doing something where you're pronated and then you're not doing anything where you're more in that neutral grip. Is that kind of what you mean by that? Or you're not doing anything where you're supinated, or sorry, you would be supinated. Is that kind of what you mean by over specificity there with that? Or yeah.
It is. Yeah, it is what I mean. Yeah. So if you're doing probably the same curls, let's just say you're doing barbell curls and you've been doing it for the last 6 months, right? That could be a cause, right? Because there's going to be a different pressure applied on the tendon than maybe some alternating dumbbell biceps curls, right? It's just a different load and pressure applied on it, right? So if you're doing the over specificity with that barbell biceps curl, can be a contributor. Because I know, like you said, you can't pin it down to any one cause, but this can be like a huge one of the leading factors in it. So yes, and I think we see that a lot in barbell specific training. Powerlifting is probably really common in because squat, bench, deadlift, that's the cornerstones of powerlifting program. But I think with bodybuilding style training, that's something that you see a lot. And yeah, so that's when I say over specificity, that's what I mean. Those movements not being changed enough. But then it's on the line of, are they being changed too much?
Yeah.
And then being over variation could be an issue. And that's like where we have an acute tendinopathy where you're not giving the intensity and volume has ramped up so quickly that you're not getting a chance to recover. And now we've got a tendinopathy going on.
And so maybe this is the case for, like you said, again, you want to walk that fine line. You don't want to change too much because that can lead to some issues. But again, if you're literally doing the same thing for extended periods of time, which there's people that hear, oh, hey, you don't want to change up too much. So then they do that. Again, we want to walk that fine line. But to me, this sounds like this is where you can make the case for using things like maybe some cables, some dumbbells, machines, right? Switching it up in between those and not just using, for example, barbell, right? And this again goes back to why I'm a huge fan of hypertrophy training, not only for building muscle, but we do really have a lot of tools that we can use in the toolbox. And again, that could be overused, right? You can abuse that, but it allows for that flexibility to where you're not like trying to pigeonhole yourself into one specific exercise, right? Where you're doing the same thing over and over again.
It is. Yeah. That's also what I like about bodybuilding style training is that you do have all those tools. And not to get too deep, but the concept of regional hypertrophy as well, you can take advantage of, right? You're pulling from all different angles, just force coming from different angles. When you do that, I think that's really important. Of course, you don't want to be, you're not going in there without a plan and just picking random exercises every week, right? Like there's needs to be some structure, and maybe you're planning it for a 6-week cycle. Maybe you're for smaller muscle groups like this, and maybe you're pushing it at a 12-week muscle cycle. But yes, these movements are ones that would benefit from change more often. So yeah, it's a fine line, right? So you have to change them. You have to change them enough. They need to adapt, and then you move on.
Okay. So over specificity, again, just like you said, just maybe doing too many of the same things, again, not changing that up. So over specificity, is there, I think you maybe had a couple other ones in terms of that you see that generally maybe cause some tendinopathy. I didn't know if you had any more on that. I kind of stopped. I cut you off on that to dive into that a little bit more.
No, that's all right. The overspecificity really plays into, we could say that doing the same thing for long periods of time, but it really plays into the overspecificity. I guess you can consider them really the same thing. And then the other one we talked about a little bit is just changing a acute overload of force from a different angle. So you're just not getting enough recovery. You're not getting enough recovery time. And that is at the core of tendinopathy. That is what it is. You're not getting enough, the tendon's not getting enough recovery time for you to not develop a tendinopathy, right? And it's interesting because you think there's this tendinopathy continuum where you have a tendon that's reactive, right? That will react to things you're doing, a tendon in disrepair. So it's like painful all the time. And then just a tendon that's what you consider would have a hole, right? And you can change those things. But when we look at the imaging, you can see that the tendons that have tendinopathy and tendons that don't actually have more fiber than the ones that are considered to have tendinopathy. So you actually have more to work with. Yes, there's going to be an area where cells have died off, but your body's actually giving you more to work with. And so if you treat it nicely and you find that area where you can come in and start training again, right? Like it's not going to be at the intensity that you want. It's not going to be at the volume that you probably want, or even you might think you can handle, but there's a place to come in with it. And it depends. Maybe if there's a lot of pain, you just start with isometrics, right? Like if pain is if we're saying that 0 is there's no pain at all, and 10 is pain beyond emergency room pain like you've never had. If we're starting at a 7, you're not going into the training session doing what you did when you were most healthy. You might be coming in with isometrics and maybe putting 70% for 10 seconds. There's like a protocol, which again, there's a protocol for tendinopathy. And I don't think everybody should be going by that just because of N equals 1 and just because it worked for 70% of this study pool, it's going to work for everybody. So you could start at 70. The protocol starts at 70% of isocontraction for 10 seconds, and you have some sets of those. And so maybe you start there if it's really painful, and then maybe you go into some tempo work, right, where you're doing intensity a bit lower. They call it heavy, slow resistance training. Not heavy in the sense that you're maxing, but heavy in the sense that you're not doing, I don't even want to say physical therapy exercises, right? Because that's not what an educated physio would do. You're doing tempo work with something that maybe you could do 15 for. And there's a specific study from 2010 that I'm thinking of where they had this protocol where they had them doing sets of 15. So maybe you're working with that. You're doing tempo work, 3 concentric, 3 eccentric on the contraction without a rest in between. So maybe you go on to that, and then you can increase intensity and volume as you continue to train, as you're gauging how things are reacting, right? And so this is probably another case where you have a client who's had this biceps pain or this elbow pain that they've had it for months. It's like, all right, it's time to refer out to physio and have them take a look at load and just the way training is going, and then get some direction on that as they're getting worked back to you, and probably working it as a team. Like, they're still seeing you, but we've incorporated some changes to loading. But I got way off of the question.
You're good.
But I think that's really at the core. And they're really talking about the things that would lead to tendinopathy. And at the core really is overutilization. Too much too soon.
Yep. Would you ever say to somebody to just not train, like, hey, you got some tendinopathy to your elbow, just don't train for a couple of weeks? Would that ever be something that you would ever recommend? Is that something that people do recommend? Is because my understanding with tendinopathy, this is just what I've heard. I don't have any research to back this up or anything, but it's just the best way to get rid of it is rest. I don't know how accurate that is, but yeah, is that something you would ever recommend for somebody here with us?
No, absolutely not. Because the tendon needs to be challenged, right? The tendon needs to be challenged, and it needs to continue to recover, right? It needs to be challenged. That's how our muscles grow and get stronger and repair. That's how we bring blood flow into the muscles, which has inflammatory mediators. And there's still a cohort, a group of people that argues that there's no inflammation and tendinopathy, and that's why we're calling it tendinopathy. But no, the absolute worst thing you could do is rest it, right? There has to be some form of work on it to make it a strong tendon. Maybe you rest a couple of days, but you want to find that entry point where it's appropriate to start loading it. And that place to start loading it could be isometrics. And that's where you have to take an N=1 approach. Like, what's this person's experience? What's their training history? What's their nutrition look like? What's their sleep look like? Because all of these things are going to affect recovery. Because if you're taking someone pretty far in a cut, the risk of injury is definitely higher because they're not getting the nutrition that they need to recover. This is something that could increase the risk. And does it make sense to go into a maintenance phase as far as nutrition? It might. If you're prepping for a show, maybe not. But you have to weigh what's most valuable to you. If the show is most valuable, the show must go on. But I don't recommend it. But yeah, so I would say absolute rest is not the thing to do. You want to find that entry point to train.
I find, and again, I don't have anything to back this up, just like my experience, but I find too that personally, from just what I can think about from my clients, the client avatar that seems to get the elbow tendinopathy the most are my male clients. And to me, I wonder if it has also something to do with, like you said, again, any injury is going to be too much too soon. And especially when it comes to pulling movements, work, just poor technique, trying to do too much weight, just trying to show off. And again, that over time seems to be something. But then but something you mentioned too that really goes into it is these are also people that they have a high stress lifestyle. They work a ton. They go into the gym and they just try to rush through it, intentful with what they're doing in the gym. They're just trying to check the boxes, and they don't sleep well, right? And then nutrition's just all over the place, and all these things just start to stack up. And this is where you see it. And I find that seems to be maybe the type of person that is at a higher risk of this. And then I see it happen a lot more too.
Yeah. So injury, mental fatigue and mental stress contributes to systemic fatigue, right? It's not just the physical factors, it's the mental factors as well. You've got stuff going on at work. You've got a proposal at work that has a due date, or maybe things are going on at home, and that's putting a lot of stress on you, and it's taking a lot of energy, right? And that takes energy to train away. When you're going to a training session with a lack of energy, that can definitely be a contributor to increase the risk of injury. Say you're sleeping for 5 hours because you just had a child. We were just talking about that, right? You just had a child, and you're waking up every 3 hours to feed them. Could increase the risk of injury, right? You're not getting proper nutrition. maybe you're just running around. You're not even paying attention to your nutrition, right? You're low on carbs, you're low on fuel, just in general calories. And so all these are factors that can contribute to injury, big factors. And when you pull them all together, it's a recipe for injury. Doesn't mean that it's going to happen, but it means that it's more likely to happen. And I really want to stress that it's not definitely going to happen. The risk increases. So yeah, there are so many different factors. And that's where this biopsychosocial social model comes into how we're dealing with people on an individual level.
Yeah, I know personally, I know volume probably plays a big role as well too. And again, we'll talk about how to lower your injury risk in a training program when it comes to like hypertrophy. But I know for me, like volume's a big one too, where once I really start to do some higher volume stuff, and I like to think I focus on nutrition and lifting with at least decent technique, focusing on sleep, stuff like that. And again, though, like I'm assuming too, probably it comes down to, again, the person. Like some people maybe are just a little bit more predisposed to it. Potentially, maybe they have a lower volume tolerance, or maybe just specific movements that they do. They just have maybe a little bit of a higher risk there of potentially just running into these issues.
So maybe, yeah, it is quite possible, right? I would say that it is possible, but I think it's adaptable. You think of excellent technique execution, right? And we think of, we'll go into knee valgus, right? It's when your knees, we'll just think of a squat or maybe even a leg press, right? So we'll just think of that. And when things start to get heavy, there can be what we call a knee valgus, where the knees start to collapse in. Now, can that contribute to an injury? Maybe. If we're thinking about a squat, it's just a natural thing that happens. We're like, when we look at Olympic lifters, it all happens to them at some point in the lift. Like it's just a natural part of the lift, and it happens. But when we're thinking of a well-executed, specific tempoed leg press or a squat, you're trying to get that not to happen. But even if it does happen, if you are introducing intensity in volume at a rate that is adaptable, it's something that you could continue to have. Now, is it the best use of your energy? I don't think it is, right? Going from point A to point B in a straight line is going to be the best use of your energy, right? Because you're using less energy and you're probably using it where you want to use it, right? You think of, so if we're thinking about your adductor magnus, let's just take that, like at the bottom of a squat, your adductor magnus starts to become a hip extensor. It becomes a large hip extensor. And if you let that happen too much, then that could be part of this knee valgus that comes in. But if we're really trying to focus on squat, let's say we're doing a front squat, we're really trying to focus on quads, right? We're using it as a hypertrophy movement, not as an Olympic lift. And we're trying to really hammer the quads. Then this might not be the thing that you want, right? We really want to focus on hitting the quads. We don't want that knee valgus. We want to be really efficient with the movement so that our quads can get the most out of it and we really can feel in the quads. I think that technique can be adapted to. If we say poor technique execution can be adapted to, but I wouldn't say that it's the most efficient use of our energy as far as hypertrophy training and really even strength training goes.
Gotcha. Cool. Yeah. So I guess then just to wrap up this, like what would be some things that you would like in terms of programming, like and just overall, just things that you work on to really try to lower injury risk, like from a programming perspective, hit on some nutrition stuff as well too. And then, yeah, just hit on anything maybe that we missed there with that. Cause I think throughout we've been talking about some things to help lower your injury risk and whatnot. But yeah, if there's any kind of big rocks for you, yeah, we'll go there.
Big rocks. There's just so many small rocks that go into it. Yeah. I think a big one, you have to have your fingers on the pulse of fatigue and fatigue management. And if someone is dragging and going to the gym, they're usually pumped to train. And they're like, I have to go to the gym. It's just another thing that I have to check off the list. They're dragging through work. They want more naps, stuff like that. If you look at their past few days of nutrition, the past week of nutrition or sleep, those are probably lead indicators that fatigue is increasing and that risk, it could be on the horizon. So these are things that we need to look at as trainees and make sure that those things are being looked after to decrease the risk of injury. I think that's a big one, is just fatigue management. I think and there was a recent piece of research that came out that talked about how, I'm not even sure that it talked about injury risk, but it was talking about deloads. And I guess it was hypertrophy, right? That don't increase hypertrophy. But I think having deloads, and maybe you're not deloading the whole program, maybe you're just deloading a compound movement and you're keeping things at the rest of the stuff, maybe it's at 3 reps in reserve, but you increase your reps in reserve. That's something that you could do. If someone's feeling really fatigued, that's something you could do to decrease the risk of injury, right? Non-over specificity, right? If you're been doing a leg press for 6 months, it might be time to come off and maybe do a Smith machine squat or something along those lines. So I think over specificity for sure, stacking volume really quickly. So if someone, like if you're on a program where you're training 3 days a week and all of a sudden you're going to put on a 4th day of week, you don't want to pump a bunch of sets and increase volume on an exercise. That could be a big risk. And I think when you're going through programs, think decreasing reps in reserve as opposed to increasing number of sets is definitely going to be something that you can do to manage fatigue. So these are all really biggies, and there's so many factors that go into injury risk that there's definitely some that I'm missing, but those are some big ones for sure.
Yeah, no, I like the volume one, right? Where you're not just, don't just ramp up your volume. Like you said there, again, what's the, the big cause of injury is too much too soon, right? And again, people that, oh, hey, I need to do higher volumes. All right, I'm just going to ramp it up. And I'm assuming that also is intensity too, right? Like that can fall into the volume side of things, like ramping up your intensity super quick, right? It's, hey, you didn't train for 4 weeks. You probably don't need to go balls to the wall the first week. Ease into that a little bit, right? Ramp that up. And this is where people, I really try to build, and I'm sure you do the same, but really try to build that consistency, because I think this is where people who are very inconsistent do get themselves into trouble and run into injury risk, right? They again, miss the gym because they're super busy. So you already know their recovery's low. Then they're like, I got to make up for last week. So they go balls to the wall, and then now they're hurt, and then they don't train for a little bit. Then they try, it's just this vicious cycle that they keep going into. So really trying to avoid those massive increases in volume can be super helpful.
Absolutely. Yeah. Inconsistency can be huge because you have a string of a week or 2 weeks where you missed workouts. And it's like you said, I'm going to go balls to the wall. I'm going to go ham. And I know that I got written a 3 reps in reserve program, but I'm going to failure on every single set. You're not making up for the work that you missed.
Yep.
And I see that all the time. And I think the advice there is hit the big rocks. Right. Even if you're swamped, like if you're working late and you need to get home and see your kids and your wife, you want to spend time with them, just go in, hit the big rocks, right? If you have a leg day, hit the compound movement, right? Hit the big compound movement and then bail, right? Like hopefully if you've got 20 minutes, right? Like you probably have time to do that. Probably. But yeah, inconsistency is another big factor for sure.
And the research on maintaining muscle, it really takes a lot less than we think to maintain. We can use that to our advantage here in these situations. Also, to go back to the deload, you were talking about deload. So again, like having some fatigue management built into where if you've been doing a ton and you're starting to feel it, again, taking these lighter weeks. Again, this goes back to the maintenance research, right? Where you can get away with it. And I don't know if this is a study you were referring to, but there was one recently where they had 2 groups. They had one that took a deload in the middle of it. And then they had one group that trained all the way through. And actually in that deload, they didn't do anything that entire week. They didn't do any weight training, and they found from a hypertrophy standpoint it was the same right at the end of it. So again, just some research there to back up, hey, potentially taking these deloads. I don't know if that was a study you were referring to. It came out within the last 6 months or so, I believe, there with that.
Okay. Yeah. That might be the one, but I like the outcome of the one that you just cited a lot better. You can take a deload, mitigate injury risk, and still have the same gains. Yeah, absolutely.
And two, again, like you hit on this throughout, but again, doing things outside of training. Again, I think people, when they think about recovery, it's always, what are the things I can do to get better? What are the things, but it's like, they don't think about, again, like you said, fatigue management, but also managing your lifestyle, sleep, even nutrition is going to play a big role, right? Because you see a lot of people that are in deficits and they're trying to work through that. And it's, hey, if you're trying to, heal from an injury or trying to improve it, again, giving yourself a little bit more food is going to be helpful there. I'm assuming though, at some point that probably the return on investment probably goes down, right? It's if you're in a deficit, getting to maintenance around there is going to be really beneficial from like a recovery standpoint. But then you go past that and it's like you get too much food, then it's like, all right, now we're going to there's going to be some lower return on investment there.
Yeah. And I think that depends on your shorter long-term outcome, right? If you might be in a slight, like if you're dialed in, say you got a show coming up, or maybe you don't, but you're just so dialed in on your macros, it's going to be about a quarter pound a week. It might be beneficial for you to take that pound over the month for healing purposes, for recovery purposes. So yeah, but I think maintenance is a good place to be. Then in a deep deficit, you're definitely in a better place for recovery. And not to say that you can't recover in deficit, because you can. You're just less apt to.
Less likely, yeah. You probably need to be on top of it a lot more with that if you're in a deficit. Cool, Mike. All right, man. A ton of great information here. I could probably talk to you for at least a couple more hours on this. I still have a ton of questions, so maybe we'll have to get you back on here again to talk a little bit more about injuries and go over some things that we weren't able to go over today. But ton of great information here. I think this will be super helpful for people. Before I let you go, is there anything coming out on your end? Anywhere where you want to lead the audience to? And yeah, we'll go from there.
Yeah, you could, if you have any questions about injuries, anything like that, you can find me on Mike_Evolve Health PT. You can email me with any questions, mike@evolvehealthpt.com, or you can friend request me on Facebook, Michael Laviolette. And yeah, that's everything I got right now.
Cool. Awesome, Mike. Again, appreciate your time, man. Thanks for coming on. And yeah, we'll have to get you on again here soon.
That'd be great. Thanks for having me on, Jeff. I really appreciate it.